not joined us yet.
Right.
Just give it a couple more minutes.
Yeah, that's marking.
Okay. So Kim's having some technical issues, so Kim will be joining us shortly. Like everybody's joined us now, apart from Councillor Redfell. So we are live now, though. So if you want to start.
Okay, yeah. Good evening all. It's now 7 o'clock. I would like to start the virtual meeting of Health and Wellbeing Overview and Scrutiny Committee. I'd like to remind everyone present that this meeting is being live streamed to the Council YouTube account and also being recorded for publication on the Council's website. I'd also like to remind members and officers to mute their microphones when they're not speaking and to use the raise your hand option if you wish to speak. I'd give everyone the opportunity to speak at the end of each item. Can I ask all other mobile phones and other electronic devices, TVs, tablets, music, etc., to be silent during the meeting? I welcome the following officers to the meeting: Roger Harris, Ian Wake, Les Billingham, Catherine Wilson, Mark Tebbs, Anthony McKeever, Lee Henley, Tina Stitch, Kim James, Andy Brogan, and Jenny Shade, and Stephanie Dorr. Are there any other officers present that I've not named? Nope. Okay, do we have any apologies for absence?
No apologies received, Councillor.
Okay, thank you. Okay, I move the minutes for the Health and Wellbeing Overview Scrutiny Committee held on the 18th of June to be approved as a correct record. Has anyone got any questions on those ones, on those minutes? Nope. Okay, to agree.
Sorry, Chair, I did raise my hand there.
Sorry, I didn't see that. So, yes, Victoria.
Great. I mean, before I go to the minutes, I just wondered how the committee is proceeding without a vice chair.
Yeah, I can answer that. That isn't for the committee to agree. That is down to leaders of the parties to agree. That isn't a committee matter. It goes to the vice chair seat of this committee.
Right, so I understand that this has to be agreed at full council according to the Constitution. However, obviously this wasn't done at full council. I think it's inappropriate that this committee's been left without a vice chair. Can you advise why this has been done, bearing in mind if something happens to you during the meeting, Chair, or you can't attend, who takes over chairing of that meeting? And in the months that have been left without a vice chair of this committee, who attends meetings when as your vice when you can't?
As I say, Councillor Holloway, the leaders of the opposition parties have had a chance to put their chair in. That will also be taken up if you wish to with Jenny Shade. Would you like to come in on that?
Yeah, sure. Hi, Councillor Holloway. Unfortunately, this cannot be decided until September Council. This is due because it's a constitutional matter that has to be agreed by all leaders.
Okay, well, just for the record, I think it does just show a really lack of respect to the committee to not have sorted this when the chairs were replaced. But I'll move on to the minutes. So at the June meeting, Chair, you said that recently you had been reminded how difficult it was for male victims of domestic violence to get help in Thurrock. You asked if there had been any funding appraisals or sources of information support for male victims. I explained that I understood that services were offered to both men and women, and it was important for everyone to receive support. I replied that domestic violence and sexual violence was an issue that predominantly impacted and affected women. I said I thought it was in the high 90%. You said on the recording, that's incorrect, Chair. You said, I'm aware of only one male shelter. you added that a 2012 figure said 40% of victims were male, and you said you saw a large percentage coming through your work. I spoke to the Sexual Violence Service, CERIC, who provides sexual violence and abuse support for any individual, adult or child, male or female. They said in the year April 2019 to March 2020, CERIC had helped 1,216 Thurrock victims. 1,179 of those were female. 37 were male. That's 97%. I also spoke to Changing Pathways, who provide free and confidential services for people who are currently experiencing or have previously experienced domestic violence. In the year 2019 to 2020, all of the people they supported were female. So that's 100%. And in this year so far, they've supported 2 men. So I just want to, for the minutes, Jenny, if that could be minuted, but I just want, again, for the record, I mean, I'm not sure where you got that 40% figure from 8 years ago, Councillor Ralph. I couldn't find it when I looked for it, but I just wanted to say I think it's really important that all of us, not just members, but you as chair especially, are correct in what you're saying, and that domestic violence and sexual violence disproportionately impact women. And I'd like that minuted but correctly from last month's and this month's, please. Thank you, Jenny.
Thank you, Councillor. As you're fully aware that in the history of mental health and domestic violence, men have had trouble coming forward and speaking out about their abuse and what they've suffered. Very much like the sexual harassment and rape cases that have been historically reported. This is what we're now seeing with male domestic violence abuses, and the figures are, as I stated, a lot higher than the 95, a lot lower than 95% towards women it was to men. As I say, these are with mankind stuff that we've been looking at. If we like, we can put it forward to our next meeting in November and have a full debate regarding the sexual and violence and domestic crime on male and female, and we can bring all the figures in and all the parties in if you'd like to do so.
Would you like me to come back on that, Chair?
Yes, please.
Yeah, absolutely. I think also it's really worth mentioning that when you do break it down, and I think it's a very complex issue why men don't come forward. And I think, you know, if that's something that you wanted to push forward, then that's your prerogative, Chair. But I think it's very important to note that when you do look at the different kinds of violence that are perpetrated on men and women, the kind of seriousness perpetrated against women is always more severe. I'm just quoting the statistics of the services provided locally for the record, to ensure that we've got the most accurate evidence for the minutes of a meeting, Chair.
Personal agenda for sour grapes. This is a really serious, important issue regarding male and female domestic violence. We'll bring this to attention in the next committee meeting, and we'll go over it with solid facts and with people that can come there and offer evidence. Are you quite finished? Shall we move on to the next agenda? I say that as a yes.
It's your meeting, Chair.
Yes, thank you. That's good, that, isn't it? Okay. So apart from that, is there anything else you wanted added to the minutes? Councillor Holloway?
Councillor Maldani's got her hand up. Councillor Ralph?
Yeah, I'm not actually seeing the hands going up, unfortunately. Councillor Maldani?
Thank you, Chair. I'm not quite sure. Are we dealing with matters arising from the minutes? I haven't got any corrections to the minutes, but I've got some matters arising from the minutes.
Yeah.
Do you want me to?
Yes, please.
Deal with them? Okay. So at the last meeting, we had Mr. McKeever in attendance, and I asked about an update on the mismanagement of funds taken from our CCG to bail out Petersborough and Cambridge CCG. And Anthony McKeever agreed to provide a written reply, a specific update in writing to members and to myself specifically, and agreed to pursue the handling of the repayment and debt. I haven't been able to see any of that within the minutes. Maybe there's a verbal update coming today, or are we expecting Mr. McKeever? I can see that he's here now.
Yes, yes.
So he can probably speak to that.
Yes, would you like to come in on that for me?
Thank you, Chair. And my sincere apologies to Councillor Muldowney if I've failed to write back as you were expecting. I did immediately pursue the matter in correspondence with the colleagues at the region, taking up the pursuit of the debt in exactly the spirit that we discussed it. I've involved Maria Wheeler, the Thurrock CCG's Finance Director, and Mark Tebbs alongside me. And in the spirit that you raised it, I've persisted in my inquiries with the region. I've had some highly technical and amusing and interesting responses, but nothing plain or clear enough to warrant me writing back to you. So I should have written with an apology for not having any substantive information to provide. But despite my best efforts, I haven't got an intelligible version of exactly what's going to happen next of the kind that you were looking for, Councillor. So, as I say, no discourtesy was intended. If I failed to write as I indicated, I do apologise. I just haven't got anything substantive by way of news. I've got back an explanation rather like the one I gave you at the time about NHS money and how it can disappear through the cracks.
Can you continue pursuing that, please, then, on our behalf? Because obviously we were promised that money to be repaid over 3 years, and that you're now the second person, I think, who's agreed to provide further details about how that's going to happen. So if I can get your assurance that you'll continue to pursue that.
Yes, I'm trying to achieve honorary Thurrock status as an honorary resident by pursuing these ones. And I have actually pursued the other fella that promised to give you an answer as well, Councillor, but I failed so far. I'll keep on it, I promise.
Right, I'm not sure that's within my gift to give, but thank you for your efforts.
Thank you, Councillor. Mark Tebbs would like to come in on that.
Yeah, just to reiterate that, we've made sure that it's on the agenda, and we will continue to kind of pursue it through the kind of finance route. So just as Max said, and just to confirm, really, we are endeavouring to kind of get to the bottom of it, and we won't let it rest.
Okay, James Towden, would you like to come in on that?
Yeah, thank you, Chair. Oh, sorry, my camera's off. Apologies. I just wanted, Councillor Muldowney's right to raise the Peterborough issue. I just wanted to say, slightly in Mac's defence, that Mac obviously is not the decision maker in the issue. So Mac can only chase an answer. I know, having spoken to him on several occasions, that he's been working very hard, ferreting here and there, trying to get certain concessions for Thurrock. So in terms of the initial people who bowed Peterborough out at our expense, I think we've given them a good going over in the past, and I know that Mac is chasing those issues now. So certainly, Councillor, those issues are certainly not forgotten, and I know that Mac is very cognisant of making a Thurrock's case for us.
Thank you, Councillor. Councillor Muldowney, is that okay for you?
Yes, that's fine.
Yeah, brilliant. Okay. Declarations of interest. Do we have any declarations of interest for tonight? No. Okay, brilliant.
Chair.
Oh, sorry. Items of urgent business. I've not agreed to any items of urgent business. However, Ian Wake will be giving us a short update of the COVID situation with Thurrock at the beginning of this evening.
Chair, excuse me, Chair.
Yeah.
Sorry, I just wanted to come in on the declarations of interest.
Yeah.
Yeah, I just wondered, Chair, that you've mentioned working in health previously, and just wondered if you could clarify if you need to make a declaration. If you work in a healthcare capacity or in a local service, should you make the committee aware of that role, just in case it may impact on what you decide to put on the agenda and prioritise?
Thank you, Councillor. Yeah, that's a brilliant piece. Yeah, my declaration of interest are listed on the council website that you are free to look at. I am a private tutor in mental health who sometimes is commission work for other providers of mental health throughout the Essex and wider area, including Thurrock Mind.
Lovely. Thank you, Chair.
Okay, do we have any items? Sorry? Did we get an echo there? Was that? No? Okay. Okay, items raised by Healthwatch. Kim James, do you have any items you'd like to discuss?
Sorry, Chair. I've just noticed there was another thing arising from the minutes, which I should have brought up if you would indulge me. Is Councillor Mays
bring that back
on
up
the
at
call?
the end? Yeah, Councillor. We move that on to the
sure.
end of business. Thank you.
We can put it in any other business. If you like.
Kim James.
Sorry, my camera's not working. No items from Healthwatch.
Brilliant, thank you. Okay. The annual complaints representation report, adult social care. Can I ask Henry to introduce this, please? So I'm going to...
Thank you, Chair. So this report is our annual adult social care complaints report for 2019-20. The main detail of this report is contained within the appendix on page 21. So I will summarise that appendix for the committee. In terms of page 21, this captures activity levels on complaints, inquiries, compliments for the reporting period, and it shows it as a comparison compared to last year. I think what's key is that this reporting period is showing a drop in complaints. 41 complaints received last year, 19 received for this year. It's also worth noting that we also write to all commission providers each quarter to establish if they have received any complaints that they may have received but not informed the council of. So we're trying to capture complaints that we may not be aware of, and if we do that, they will be recorded in our figures. What page 22 shows is that 79% of complaints that were responded to were responded to within time frame. That was 15 complaints out of 19 complaints. Page 22 also shows that 61% of complaints were upheld. That's based on 11 complaints out of a total of 18. Pages 23 and 24 captures key learning for the reporting period. And I think what's evident here is that the key themes are around quality of care and some communication issues. But we do have a low number of upheld complaints, only 11. We need to take that into account. Page 25 and 26 shows the areas that complaints relate to for both internal services and commission providers. And on pages 27 and 28, that identifies the areas where the complaints were upheld. And on page 29 is a summary of local government ombudsman inquiries that have been received for the period. Happy to take any questions. Thank you.
Councillor Muldowney's got a hand up. Councillor Earl.
Mute, yes, Chair.
Councillor Earl.
You're mute.
I think you're bringing me. Sorry, I couldn't hear then whether I was being brought in or not.
Yes, you are. Sorry, Councillor.
All right, thank you. Yes, so it seems like responses are down across the board. Do you think this is there's been a COVID effect in terms of less reporting of compliments and complaints? And also, I know when we looked at this report before, we did have a discussion about how, we would rather not necessarily get more complaints, but have more feedback and response from people. And there was a feeling that sometimes people might feel afraid to make a complaint about the care that they're receiving because they feel that the care is taken away, etc. I wondered if anything's been done with the last report, this report, to address that.
Okay. I mean, my view, I don't think this is a COVID issue in terms of the reduction, because the reporting period for this was end of March this year. So the numbers are lower in terms of complaints and compliments. In terms of compliments, it may be, I mean, I think if you look on, I put a note on page 31 of the report. So we may have received as a council, a greater number of compliments, and they may have not been sent onto my team for logging onto our system. So that could be a reason why there has been a drop in compliments. Complaints down, which is a good thing, but we're not. We want to receive complaints to look at learning, and as I mentioned as part of my intro, that we do actively communicate out to commission providers to make sure they haven't received complaints, that have not passed those on to the council, and that's all been factored into these figures. So I think it's a positive thing that complaints are down, but we're still doing that active kind of work with commission providers to ensure they are passing complaints on to us. We're also producing communication for commission providers in terms of leaflet form, that can be put up in care homes to promote the fact that people can complain and to promote our channels that they can complain to.
Thank you, Councillor.
Thank you.
Okay. Lee, can I ask how easy is it to make?
Sorry, Chair, I didn't quite get that last bit. It broke up.
Yeah. How easy is it for someone to make a complaint? Is it a situation like? It have to go to an email or something like that. So I'm getting a gecko coming from on the street.
So I think I've got it. I think I've got most of it. I mean, we've got a number of channels that people can complain. We've got we've got telephone. I can complain by telephone, email, letter. So it really is easy to complain. And we've also, I mean, not everything's a complaint. If we can resolve the thing as part of initial feedback, so it could be, a low-level matter that doesn't really fit our definition of a complaint, we'll try and resolve it that way. But anything that meets the definition of our complaint, we would always log as a complaint.
Thank you. Okay,
can I come in from the service, Chair? So just to there is a isn't there? Sorry. I don't know if
sorry, could everyone put on microphones apart from
I think just to reassure members from the service point of view that complaints are taken extremely seriously. It is part of the induction for all staff. We regularly produce leaflets that go out to residential care homes for domiciliary care and to all our in-house services. It's very there is a confidentiality is absolutely protected at all stages of the process, but we realise that service users sometimes do feel vulnerable, particularly if they're in a caring setting, that they do worry about if they do make complaints, although there's no evidence to support this, that they might be reluctant to complain because they're worried about losing the service in some way. So people do involve Lee's team, who are not part of the service. They're independent from adult social care, and they will give an element of confidentiality and an element of independence. But we also support advocacy, so people can go to advocates. We encourage people to use Healthwatch. There are numerous channels at which people can raise complaints. I do think, in a way, it's positive. You could say it's positive that it's gone down to 19. I actually say it's most probably. I would turn that on its head, and actually, I would like to see slightly more complaints, because I think it keeps you on your toes. It allows us to look at areas for learning, and a complaint isn't always a negative thing. It is sometimes an opportunity to change the way that you're working. So just to reassure members that it's treated very, very seriously within the service.
Thank you, Roger. That's sort of why I asked how easy it was to make a complaint, as if there's ways of making it a more acceptable process that people are not put off by the procedure of doing it. Okay, Councillor Vettel.
Thanks, Councillor. Can you hear me? Yeah, Lee.
Yep, can hear
you. Good report. It's brilliant. I'm just going to ask what Roger's just answered anyway. So, because it's good to think, things keep coming in to actually keep you, as you said, on your toes, Roger. And as you say, some people may not put complaints in case of. My only question is it because of COVID that we've got a lot of not available or not applicable on there, Lee?
Just
On page 8.
this covers the period up till March the 31st. So it's the last financial year. So it was very, very limited period that overlapped with COVID.
Okay, lovely. Cool. Yeah, cheers. Thank you.
Councillor Holloway.
Thank you, Chair. I do have a question for Lee and Roger, but I just wondered, Chair, I'm going back to urgent items because you mentioned Ian's going to give a verbal update in urgent items about COVID, but then we didn't get a verbal update about COVID. So when is that going to be on the agenda? Because it's actually not on the agenda. Can you just tell me where that is before I ask Lee and Roger the question, please?
Yeah, that is the next item. Thank you, Councillor.
Okay, lovely, thank you. Yeah, my question actually, Roger, you brought up, knowing that this comes up every time about the concerns of vulnerable people not wanting to come forward because of repercussions, and it's so good that there are so many places that they can kind of put their complaints in. However, they ultimately might still be worried about any complaint having repercussions, no matter where it comes into. How does reporting it to different places mean that it's less likely that they might suffer repercussions? Because I think a lot of vulnerable people will think any complaint, no matter where it gets told to, might involve repercussions. So can you explain a bit how that works and what we're doing to ensure people feel most comfortable about not worrying about those sorts of things? Thank you.
So I suppose the point I was trying to get across is that there are numerous channels outside of the direct service provision that person is receiving where complaints can go. So it could go to Lee's team, who are not part of adult social care. Remember, a lot of our providers are independent of the council. So if it's domiciliary care, residential care, they may come to the council. Similarly, people may well go to Healthwatch, because obviously Healthwatch covers social care as well as the NHS. So I suppose we allow people and encourage people to use opportunities outside of the direct care setting. That was the point I was trying to get across.
Okay, no, that's absolutely fantastic. And also just to say, of course, hope the low rates of numbers does indicate that the services that we're offering are good. And actually, I know the staff work incredibly hard and are wonderful staff. So I'm hoping that reflects that in that numbers. So, yeah, thanks all.
Thank you. Kim James.
Thank you, Chair. Obviously, Roger's picked up on Healthwatch involvement, and just to say that we do get calls from people who are concerned about making formal complaints. If it's within a residential home or in a domiciliary agency, we tend to, if they really don't want to make, or they're frightened to make a formal complaint, we tend to direct that to the monitoring teams and explain what the situation is. They quite often do unannounced visits to them to look at those specific subjects that have been brought up. But I think every year when this item comes up, I always ask the same question, that we really do need to link in with Lee and the complaints team to be able to feed back and tell them, out what's going on, and form that kind of a relationship where we can make that phone call and say, they don't want to make a formal complaint, but you need to know this. This is the process we've taken for them or got them an advocate. Because I still think that needs to be picked up and monitored, those numbers. We put it on our monitoring, how many complaints we've had around social care, but I don't know if that actually gets fed into this report because it wouldn't have been investigated. So I do think we need to tie that loophole up.
Lee, could you come back on that for me?
Yes, sorry, Kim. What service area are you? Just so we can, because we do make contact with the Caroline Peters to capture some, to make sure we're capturing all the internal service complaints as well as those commission provider complaints. So we do that every quarter anyway. But what service area are you referring to?
So we're Thurrock Healthwatch.
Healthwatch.
Yeah, so we oversee listen to people about their experiences of using health and social care services within Thurrock. So we are independent.
Okay. So at the moment, if you receive a complaint, what do you? So you put it on a monitoring sheet, and what happens to that sheet at the moment?
Well, we feed any complaints, issues or concerns and good experiences back to commissioners to raise our concerns. At the moment, if somebody's got this speaker on, at the moment, if we get somebody that doesn't want to make a formal complaint, we will take that back to the monitoring team, to your monitoring teams at adult social care. I also meet regularly with Roger to raise any really serious concerns that have been raised, or even Les. So I'm not sure that it feeds back in. Our monitoring that comes back to the council, our council monitoring, asks how many complaints we've received regarding adult social care. So those numbers do go back in, but I'm not sure they're fed to you, which is what I'm saying. We need to close that up. So maybe we're offline. We can have a catch up. I'll give you a call or drop you a line and we'll meet.
Yeah, that sounds great. We may capture it, but I wouldn't want to mislead anyone. So we can have that conversation to make sure we do.
Thank you.
Thanks, Kim.
Councillor Massey.
Thank you, Chair. Thank you, Lee and Roger, for the report. It's great that complaints are down. That's absolutely fantastic. And on page 25, complaints look down generally across all of the areas apart from one. I just wondered if there was any correlation in the rise in complaints for years 1920, any link, a common factor. And then also, it's great to see the compliments on page 31. I haven't seen the compliments from last year. Are you planning to show in future the various service areas in regards to compliments across the years in previous?
Okay, yeah, good point on the compliments. I can do that for the next report. It's a very good point. Thank you for that. In terms of your point on page 25, are you referring to? Is it the Collins House? 25. Is it the increase in Collins House complaints?
Yes, that's correct.
Yeah, I mean, again, I think we've got to be cautious. We're still referring to it as a low number of complaints for the year. So I think what that's shown is 4 complaints were received, and all 4 of those were upheld. But it's still a low number. I think looking at the upheld element of those complaints, if there was a theme, it was around the quality care based on those 4 complaints.
Kim James, you have your hand raised.
Sorry, that's an old hand.
Okay, thank you. So we have that report as noted. Move on to the next agenda. Thank you, Lee.
Thank you all. Thank you very much, Chair.
Okay, so the added item is the report on the COVID update.
Thank you, Chair. I've done a very short PowerPoint presentation you will be pleased to hear, which I can just share now, which pulls out some of the highlights, if I can work out how to do that. Can I check? Can you see that? It says Thurrock COVID-19 dashboard.
Yes, we can see that. Thank you.
Okay, marvellous. So this is a dashboard that we produce and update daily. So I've got a whole team, an intelligence and surveillance cell that is monitoring a whole range of different metrics. There's a huge amount of data on this that I'm not going to go through all of it unless people really want me to, but I've just pulled out some highlights. So I guess the main thing to take away is that our threat level at the moment is still very low. So the outbreak control plan defines 4 different threat levels for Thurrock from 0 through to 3. We remain at level 0, which is the lowest level. The R value, I've heard a huge amount in the media. For the east of England, we estimate to be between 0.8 and 1. You can't actually calculate it meaningful at a geography below the east of England. So that would suggest that the growth rate is between -3 and 0% per day, which is also good news.
In terms of the absolute number of cases, we are receiving quite a lot of data now, albeit in various different forms that we have to link together. But we're doing that. We've got, in the last 14 days, 21 separate cases in Thurrock. 21 at lower super output areas with cases in the last 14 days. So this is kind of sub-ward level. The rate per rate of cases per 100,000 population in the last 17 days is 5.16. This is the metric that the government obsesses about, and it's the metric that's used primarily to decide whether or not to move an area into lockdown. That is actually quite low compared to national levels. So out of 198 local authority areas that we received data for, we're ranked 135, where 1 is the highest and 198 is the lowest. There is a little bit of evidence that the number of positive tests and the positivity of tests, i.e. the percentage of those who are tested that test positive, has increased over the last 7 days. So particularly this positivity rate, so the proportion of tests that are positive, has peaked just under 5%, albeit still with very low numbers. And again, this data, it's not on the dashboard, but I was looking at in my leadership team this morning. Very slightly concerning. You can see, over the last couple of weeks, our 3-day rolling average of number of positive COVID-19 tests has maintained within this area here between just over 0 and just above 2. The latest data is showing it's just breaking out of that range. So we do need to watch this very, very carefully. If that trend were to continue, then we might want to think about our threat level going from 0 to 1. So we do have a few cases that the number of LSOAs that have got a positive case has increased in the 2 weeks that I've been on leave, although I'm sure those two things are not in any way connected. But we can't see any connection between them at the moment. So they seem to be kind of random cases. I thought this was interesting. So the average age of those testing positive is decreasing. So you can see back in March it was 63. In August it's dropped to 30. That could be one of two things. It could, or actually both of them. It could be a function of who we're testing. So if you think back in March, testing wasn't generally available to everybody. It was generally only available to those who are admitted to hospital. And we know older people are much more likely to be admitted to hospital if they become infected. Or it could also mean that there is a genuine increase in transmission in younger age groups, which would mirror what's happening nationally and actually internationally, I think, to a large extent. But we don't actually know which of those two things that is. What is really good news, though, is that there's no evidence at the moment that any increase in positivity or any increase in numbers is translating to health or care service usage. So this is from our SITREP. We can see we've got only one BQH critical care bed occupied by someone who has COVID, and no other hospital beds, only one case within residential care homes at the moment. And if you compare that, so this is the ITU, this is the most serious, to what was happening earlier on in the epidemic, you can see a sustained fall. This is a really good metric because it's a very accurate way of calculating prevalence in the community, because we know a certain percentage of everyone who gets COVID will end up in ITU. So if there is any increase in the population, it's not actually translating into much public health harm because it is not resulting in people being admitted to hospital. So it's the hospital usage and the health service usage metrics that are the ones that I'm most concerned about, because obviously if COVID or if any second wave of COVID is causing an increase in hospital admissions, that we know that's causing a public health harm. And I'll stop there and ask any questions. And let you ask any questions, Sharon.
Thank you, Ian. And quite a comprehensive report for such a short notice that I gave you for that. One of the questions is, obviously, the age we were looking at was 30. and a slight increase in the area at the moment. Do you think that has anything to do with people going away on holiday?
That's a really interesting point, because certainly when ECC looked at this and they were talking about this today on DPH call, they did find some evidence that there had been some seeding from abroad, particularly from Croatia, interestingly. I haven't had a chance to look in detail in terms of our own numbers to determine that, but the absolute numbers are very, very small anyway, so it will be difficult, I think, to say with any certainty that that affects happening with Thurrock.
Thank you, Ian. Councillor Muldowney.
Thank you, Chair. Thank you for that report, Ian. It's reassuring to know that our threat level is currently at 0. I hope it stays that way and we don't have a current wave. Of course, the main thing that's happening this week is that children are going back to school. I know from my own personal case, my son is currently in a bubble with his year group, so that's actually 240 children. So I was going through a little, very rough statistical analysis of how much risk that exposed our family to, or individual families, in terms of the school. I understand from the school's point of view they're doing the best job they can in terms of having to get kids back and not having the space to be able to do more than that. But that the risk of that does that number of people that me and my family are now in contact with has just raised exponentially just today when my son went back to school. So I was wondering, it's obviously speculation, but what do you anticipate the impact will be on children going back to school?
I'm always very, very wary at taking up the invitation to make predictions in terms of this epidemic, because I think anyone who can tell you with any certainty about what's going to happen in the next 3 or 6 months is not probably telling you the truth. In terms of children and young people specifically, as the epidemic has gone on, we've learned a lot more about risk. So we do know now that not everyone is at equal risk. Your risk kind of increases exponentially after about the age of 50. So children, we know with great certainty, if they do become infected, are very unlikely to have any serious health problems, virtually never get admitted to hospital and never appear in the death statistics. There is some emerging evidence base that actually they are less likely to contract COVID-19 in the first place, and they are much less likely to transmit it if they do contract it. So on the large-scale studies that have been done looking at children in schools, and largely in Australia, because they've kind of opened up before us and are kind of in a different season, so they've had their winter. What you find is where you do get the odd positive case, they generally don't, for some reason, transmit to other classmates or to teachers. In fact, most infections from teachers have been picked up in the community rather than from children. We think this is because they have a different clinical syndrome, so they are much less likely to actually have respiratory symptoms, which would allow them to transmit, and more likely to experience the disease in terms of gastro problems or abdominal pain. That's about as much as I can say in terms of certainty. But to try and put your mind at risk, the risk of 20 or 30 or 240 children in a group in terms of transmission is much lower than if it were the same number of adults.
Thank you. That is very reassuring. I have still cancelled going to my mum's partner's 90th birthday party, though, or birthday, going to visit them for that, just in case. But thank you, and that's really helpful.
Thank you, Councillor. Councillor Rigby.
Thank you, Chair. Thank you very much, Ian, for that report. Just a couple of questions. Currently say we're at threat level 0. At what sort of threat level do you have to raise to before there's any thought of any sort of local interventions? And how local are local interventions. So, for example, I know in the media there was concern about increasing Corringham. Would sort of any local interventions be able to be in as narrow an area as Corringham rather than across the whole of Thurrock? Just sort of wondering what would happen in that sort of case.
I don't think that you should assume that because we're at threat level 0, there's no interventions. I think my team would be quite offended if I was suggesting that they weren't doing anything on this at the moment. So we have detailed protocols for various at-risk settings, and there's a whole range of preventative work that continues to go on within those settings. So, for example, within care homes, we've got the Care Home Hub, we've got a programme of enhanced testing for all care home staff, whether they are symptomatic or asymptomatic. Similarly, in schools, there's been a huge amount of work done in terms of getting schools out, and we've launched 2 videos aimed at parents and children. We are risk assessing settings all the time. So in terms of interventions, it is much more effective to prevent the disease from transmitting than to try and deal with an outbreak. If we do get an outbreak in a specific setting like care home, then again, the protocols, or in any other setting, there's really detailed protocols about how we manage those outbreaks. So that's going on. We've got one minor outbreak in a care home at the moment, which is one case, but we've immediately descended on that to put in place measures to prevent that spreading. In terms of where I think you're going, which is, or correct me if I'm wrong, but in terms of a kind of large-scale lockdown as an intervention, that's determined through advice from PHE to central government. They review the data every morning, and it's that metric that I spoke about earlier. It's that the rate of cases per 100,000 in the last 7 days that they generally look at. So where you can see that increasing considerably and getting over a threshold, they tend to look at the top 20. So we're at 135. So we're well away at the moment in terms of that metric from any type of kind of national intervention at Thurrock level. In terms of our own threat levels, if we were to see evidence of sustained community transmission, we would raise that to threat level 1. Or if we were to see a major outbreak in a setting, or substantially the beginnings of an increase in terms of hospital admissions or adult social care outbreaks, that would move us to a threat level 2. At threat level 3, where we've got clear evidence of sustained exponential community transmission, that moves back to response at the strategic control group at the ERF level, because we're kind of then into, I think, a danger of local lockdowns, but we are nowhere near that threat at the moment.
Thank you.
Thank you, Ian. Councillor Holloway.
Thank you, Ian, for your update. It's really helpful to have. And I think just to say a huge thank you for everything that you've done and your team, and obviously everyone across the teams and social care staff who have managed to keep our cases really low, because it is the staff looking after people that have managed this so well. So it's just really fantastic, and we should be really proud as residents of Thurrock. I mean, a lot of questions were answered. Councillor Muldowney covered the one about schools that I was going to ask. But I was going to ask, Chair, if this could be a standard item while we're still in the pandemic, because of course reading it we didn't see any update at all, and it was just kind of slipped in at the last minute. So if this could be a standing item, whether or not verbally with the presentation, would be fantastic, but just so that it's on the agenda every single meeting. Thank you.
Yeah, thank you, Councillor. Yes, definitely. I would like to see that put on as a standing item. Councillor Vedson.
Councillor Redstill, you're on mute.
Can you hear me now?
Yes.
Yeah.
About that. Thought I'd switched it back on. Councillor Holloway has just asked what I wanted to ask, but just to say that the slides that you just showed us, Ian, in the first place, they're obviously not on our agenda. Is it possible to send them out to us? Because that's a good point. When we've asked questions from members of the public, we've at least got something to go back to.
Yeah, by all means. I mean, I can do a formal report. The problem with formal reports is by the time it comes to HOS, the data will be out of date, which is why I've tended to like to do presentations on the night, because at least you'll get the absolute latest numbers. But I can certainly distribute this after the meeting.
Thank you. I just thought those were good for us, because when it's so many rumours travel round, we've at least got some data to go back to, you know, when we see them in front of us, which is good.
Sure.
Thanks, Ian.
Yeah, thank you, Councillor. Yeah, I agree, especially when we had the report from Cambridge University or something like that. Listener says at Watch Council or something, and there's a completely inaccurate. Yeah. Councillor Rigby, you've got your hand up again.
Sorry, that's a mistake.
Brilliant. Thank you, Ian. And I say, yeah, we'll add that to a standard item at the beginning of these meetings in the future while we're actually in this situation. Thank you. Okay, item 7. Temporary reconfiguration of NHS beds across Mid and South Essex, including Mayfield Ward from Thurrock Hospital, Brentwood Hospital. Can I ask Tina Stitch to introduce this, please?
Yeah, good evening. Hi, it's Tanya Sitch. I think everybody knows me, but just to...
I do apologise.
No worries at all. Just to confirm that I'm Partnership Director, so I'm actually employee of the council, but I'm also a joint appointment with NELF to run the beds at Brentwood Community Hospital, which is why I was part of writing the report. I think, as Ian just alluded to, the trouble is with writing reports, sometimes they're out of date by the time that you get them to Overiview and Scrutiny. So I'll give you a little bit of background on the report tonight, but actually we've moved on quite considerably, and Stephanie Dawes here, who works across the MSC, who will be able to give you an update on some of the decisions, which will be really helpful rather than me going through all the options. So I just wanted to give a little bit of background to say that the beds, as we know, and we spoke about this previously, the Mayfield unit was moved to Brentwood Community Hospital as part of the COVID pandemic response. It was very much led due to the need to have the beds in one site so that we could use the scarce resource of the medical staff and the clinical staff that needed to deal with the increased number of beds that were predicted to be needed. It was only ever a temporary measure. I know that there have been some concerns, and I'm sure that you'll want us to respond to some of those, and we'll come to that. Actually, there's been an awful lot of very positive feedback regarding the moves and the beds being consolidated into one place. The staff at Mayfield, I would just like to say, and I'm sure it was recognised last time, have been absolutely fantastic. Having moved to Brentwood, they've been supported with transport, but it's still a huge upheaval and moving them to work somewhere differently. They've absolutely embraced that. They've worked very well together as a team on the ward, and they're to be commended for that. We did have an also lot of redeployed staff as well, so we had to, in order to support the beds that we've been providing at Brentwood Community Hospital, a number of staff from our corporate services and from our children's services actually have also supported the beds. So we've been able to provide the community beds that were needed to respond to the pandemic. There was always, this was a short term, and then we were going to bring that today what the medium term response would be. So this is from now until March the 31st. And then we're going to look at what the long term need is across the Mid and South Essex for community bed provision. And while that piece of work's being done, we need to prepare how we're going to cover winter, potential for a second wave of the pandemic, but also we need to think about how we're going to cope with winter and the extra beds that are needed. So I thought it would be helpful that rather than go through the options, there were a number of options that were considered. They've all been equality impact assessed. We've taken into account feedback from staff, taken into account the medical model that would work best, but also the funding that's available, lots of other considerations. And Anthony McKeever is also, as you know, at the meeting and can share the some of the decisions and the fact that we had to embrace all partners, all CCGs, all of our GP colleagues, our local authority colleagues, community provider colleagues in the decision making. But if you're happy, Chair, I'm going to hand over to Stephanie Dorr, who'll be able to give you an update rather than go through the options. I think it's much more important that you hear what the update is and the outcome of the considerations.
Yeah, brilliant. Thank you.
Thank you, Chair, and thank you, Tanya. So just to introduce myself, I'm Stephanie Dorr. I'm the Chief Nurse and Exec Director of Integrated Care for our services in Essex and Kent on behalf of NELFT. I also have a joint appointment undertaking the same function for Provide across in Mid-Essex as well. I guess, firstly, just to thank colleagues and indeed your constituents through you for the support that you've given through a particularly challenging time. And the fact that we did have to relocate some of those beds was never going to be an easy decision and always impacts quite personally, I think, on local people. So really do thank you for the support that you've given us to date. As Tanya says, it was always only a short-term solution. We kind of rapidly mobilised those new wards at Brentwood and needed to do that at pace in order to give ourselves enough capacity across the system, but also thinking locally again of people in Thurrock. We recognise that there are weaknesses when you do that. So we've had to reconsider at this point as well, when we've seen the Simon Stevens letter. As Tanya says, we need to think about a potential wave 2. We hope not for Ian's team's sake, but there is speak of that, of course. And we need to also ensure that we're fit and ready for winter. One of the things that has been pretty remarkable throughout all of this really is that joint working across health and social care. I can honestly say in my nearly 40 years, I've never seen it work so effectively. And I think there's a real desire to maintain that going forward. I think together, what we bring collectively to the table for our residents is remarkable. And I really genuinely want to see that continue. Tanya outlined there were originally 19 options. So going into this next short-term phase, there were 19 options. And a number of us, and I sort of scratched my head there, I think that's what we've been doing for some time in trying to understand what is the best option, considering the kind of patch that we cover. So we really had to think about all parts of Mid and South Essex and to get this right as best we could. So we took some decisions to our clinical cabinet, which is held across the system. Should I pause there? I can see a hand go up.
Yeah, Councillor Vettel first.
Sorry, that's up from before. My apologies.
Councillor Holloway, would you like to come in?
No, can I just hear the rest of the presentation before I come in, if that's okay? Okay, please, Stephanie, I'll allow you to continue. I was just being preemptive for when you were finished.
Okay. All right, thank you. Thank you. So many options. We took some through our clinical cabinet as well, because we wanted to ensure that everything that we consider has the backing of clinicians across the system, so whether they be from our acute trusts or community providers. And there were a couple of kind of issues that we wanted to ensure that we could take forward. One of those was to reduce the number of sites from which we delivered services. And the rationale behind that is precisely what Tanya was describing in terms of limited resources. So you won't be surprised to hear that as we went into COVID, we already held a number of staff vacancies, clinical staff vacancies, which is a national issue. And with people then becoming unwell through COVID or shielding, that coming together on those single sites gave us the ability to get a critical mass and try and manage safely on those sites. One of the things that we have also been required to do, again, is not something that we come to readily, is to take on a number of temporary staff, so agency staff or those that work on our temporary banks. some organisations, as we've come into this next phase and considering what we need to do, had some kind of red lines, if you like. So there were some constraints that we were working with as well. So what were those things? One was around, as I say, we wanted as fewer sites as we could possibly manage in terms of the staffing. The other thing, actually, and interestingly, you were talking about complaints earlier on, and we have seen some complaints coming through, I think, your lead council member, and I think we've had some from MPs as well, about some of the environmental issues that have been experienced in Brentwood Community Hospital. It was set up as a field hospital. It certainly hasn't got the right environment for anything longer term. We've had health planners come to visit Brentwood Community Hospital and have indicated what we would need to do to manage that for a sort of medium term up to the end of March. And so we are undertaking that work to give us things like day rooms back, to give us things like natural lighting back. So there are a number of things and quite a significant investment that we will make into Brentwood Community Hospital to make that appropriate for the sort of medium term. One of the other things that's been pretty critical through this is you will know there's been a need to ensure that we can get people out of hospital quickly. In our community hospitals, traditionally, we've been dependent on GPs outside of usual working hours. The national guidance has required acute trust to discharge people within 3 hours. And going into this next phase, we still maintain that position and indeed need to be in a position in the community where we can admit and discharge people 15 hours a day, 7 days a week. So that required an additional medical oversight that we previously haven't enjoyed, because we're seeing a higher acuity of patients as well. Ultimately, all of those decisions have been kind of tested and discussed, and the position that we have landed on is as follows. We will be holding 20 beds at Housestead. So this is in the Mid-Essex system, in Mid-Essex, slightly north in Mid-Essex. So 20 beds at Housestead, and these are for intermediate care. So the same type of beds as you previously saw in Mayfield. There will be 16 beds going to Kick down in Southend, Rochford to be precise. There will be 50 beds retained in Brentwood Community Hospital that will serve the sort of southwest arena. And just to remind colleagues, we will be investing in that environment to ensure that we can do the best that we can by our people. And there will be 24 beds returning to Mayfield, again for IMC beds. On top of that, we'll be providing 16 stroke beds in St Peter's, that's in Malden, and there will be a further 6 stroke beds available down in Rochford at Kick. So in total, there will be 110 intermediate care beds available, and there will be 22 stroke beds available. As Tanya says, we have done an equality impact on all of those options, and that's the one that came through as the favoured option, taking again everybody's consideration, thinking about local populations, thinking about the chairs of our CCGs and indeed yourselves as elected members. So I will pause there and happy to take any questions, and Mac also is here to take questions as well.
Thank you, Stephanie. I'm sure people will be pleased to hear that we have beds returned to Mayfield. I'm going to pass it over to, first one was Councillor Holloway.
Thank you, Chair. Just to confirm, according to this report on page 62, Mayfield was already a 24-bed unit at Thurrock Hospital, and so you're telling me that that ward is just going back to exactly how it was previously?
24 beds to Mayfield, yes.
Right. fantastic. So it's come back already.
Well, it's not come back already, but it will come back.
But it will. And is that in March or in September?
No, that will be September, end of September, beginning of October.
Fantastic. And is the intention that this is this just what's going to happen over the next 6 months, or is this how it's going to be? I ask this question because obviously a number of times in the report, the first time it's mentioned on page 33, it says to understand the permanent capacity, need and potential of the model post 2021, there's going to be, there might be another review of this. Of course, I'm very, very anxious that this might not be a permanent solution. And of course, while I very much understand and do support that you all and the NHS have done an extraordinary job in moving around beds and resources during the pandemic, and it is your prerogative, obviously, as the NHS, to do what you need to do. You do work across a Mid and South Essex footprint, as you regularly say, and as this report says. However, we're Thurrock, and we are always saying, we want to know about Thurrock. Things have to move. Things may have to move temporarily. However, we can't have any resources moving away permanently from Thurrock. As you know, we're already losing a hospital. We can't afford to lose any other resources in any way, shape or form. So absolutely delighted that this is coming back, but I would appreciate assurances that it's going to stay in Thurrock and not going to be changed. Also, one further question was, I was a bit concerned when it discussed a full business case mentioned in the report, and that full business case will need to be completed, but I was concerned that it said the business case would include a strategic context, economic analysis, commercial approach, and a financial case. I didn't see anything about patients or residents in the business case that's being proposed. Sure, financial elements are one element, but surely the patient is the most important, and their family. So if I could just get that assurance that they'll be considered and that the resources will be staying in Thurrock, I'd appreciate that. Thanks for your presentation, Stephanie.
Thank you. Like you, people are the most important thing. So, I've been a nurse all my life, and that absolutely is the focus for me. And indeed, I don't think anyone I work with would disagree with that. The resource will always be available for Thurrock residents. Now, you can hear I'm couching that, and I'll be perfectly honest with you. What we're trying to do is to get the best health outcomes that we possibly can for all of our patients, or people as they are, that live in the community at the moment. So Mac will tell you that he's commissioned a couple of very senior clinicians to help us with some of this work. So one of the things that we had endeavoured to do was to create a single stroke unit for people of Mid and South Essex, and that's because they get better health outcomes. And so whilst I completely understand the importance of local services, there's also something really important about, is it better that I am a bit further away from home, but I can walk again, I can return to work, and I can return to my family? And all of those things have to come into any consideration. So there is a piece of work that we will be doing longer term to look at what's the right thing for people, and to get the best health outcomes. So I won't sit here and say we will definitely retain Mayfield, because I want to be very honest with people, but equally we're not saying that we will move it. So I think where we possibly can, there will always be local services and local resources.
Thank you, Stephanie. If I can come back in, Chair, I think our concern, probably quite understandably, is that whilst I completely agree with the principle of, making sure that we have specialist hospitals and specialisms, and that does, have positivity with regards to care, and also workforce is another issue that is usually mentioned. I think my concern for workforce, and I know that this is a driving factor that comes up regularly in the report and in the analysis that's been produced, but I'm concerned that if we are trying to recruit here in Thurrock, Thurrock. We are trying to provide services in Thurrock that people want to come to. If slowly they're being dripped out to other places, we're not going to attract a workforce that want to stay here. You know, the staff in Mayfield, you know, as you said, have been absolutely fantastic. They have travelled, but people want to live and work in Thurrock. If people come to live and work here and then their jobs are moved, then no one is going to feel like, and they can see that things are slowly being moved out, our hospital, of the odd bed, this or that. They think, actually, Thurrock probably isn't the place I'm going to want to be, because I can see all of their services are being moved into surrounding areas. So how can that be correct? And how do we make sure that services are kept in Thurrock so we can get the workforce?
So I think one of the other things to say, and I agree with you, but one of the things is also about home first. So whilst we're here talking about beds at the moment, and I know that's been a really critical issue during this period, what we're also trying to do is continually offer home as the first destination. And in order to do that with people who might ordinarily have been in a bed, we need to provide them with specialist services locally as well. So I would always see that Thurrock would be a great place to live and work, and we would certainly want to encourage that.
Thank you.
Okay, thank you. I just want to bring Council James Holden coming.
Thank you, Chair. First of all, I really welcome the decision that we're going to see main service return to Thurrock. Obviously, it was purpose-built for this reason. We all understand the reason as we went into COVID and the need to not just create capacity in beds, but create capacity in consolidating workforce. So the reason for the initial move was wise and sensible. Just, I think the reason to now return is wise and sensible. Obviously, myself and my officer have been working with NELF for several weeks on this issue, and the one thing I would like to say is that winter pressures are routine for adult social care, so we can't see further service changes just by throwing out a phrase like winter pressures or throwing out a phrase like COVID. These are routine things for adult social care, and certainly for myself as the cabinet member for social care. You know, I look at Oak House, the facility that we created for COVID, that we are now going to maintain well into next year. That's additional, which is what we should be doing with winter pressure. I think that's what Councillor Holloway was alluding to. If we've got winter pressures, if we've got COVID pressures, we need to create additional systems to cater for that. So moving structures out of Thurrock into other areas, simply citing COVID or winter pressures for a crisis situation that we were in a few months ago, yes. Long term, not appropriate. And I would say that now that we've finally signed off the torturous process of the Memorandum of Understanding across the STP, we've articulated how we want to work together as we go for ICS status. We got into a situation where we started seeing significant service changes, so beds leaving Thurrock on a medium to long term, totally against our will. Yeah, that would be a very significant variance with that Memorandum of Understanding. So I would just like to couch everything in saying that whilst I understand emergency action at the time, and I think it was the right one, and whilst I understand this change now, and again, I think it's the right one, a permanent move to see facilities leaving the borough really would be a significant variance to that Memorandum of Understanding, specifically the section that place should be the primary planning area. And we would not want to see, so I don't even think my signature is dry on the memorandum yet. We would not want to see a situation where the system, the rural system, intervene and gazump place so quickly. That would be a retro move. So I think we've got to a great decision at the moment. I really welcome what NELF has done, and obviously I'm thankful for the staff what they have done during this crisis. And I'm hoping that this continued locality of services at the place setting is going to be the long-term trajectory.
Yeah, thank you for that. I mean, I think, again, you mentioned things like Collins House and Pick's Corner. Again, we've been working really closely with your officers to make sure that what we offer is that cohesive package, and recognising that we need to have those beds available there for Thurrock residents. So thank you, and I welcome your comments.
Thank you, James. Councillor Muldowney.
Thank you, Chair. Thank you, Stephanie. Yes, I really welcome the decision to move the beds back to Mayfield. Can I echo the concern that I had when reading the report, and also the way in which you couched your terms, which doesn't exclude a permanent move. We have been continually promised that Thurrock services will be staying in Thurrock. We've been through this with the closure of all hospitals. We've been promised this over and over again. Obviously, we understand the need to move because of COVID. We're glad to see them moving back, because I must say I felt the tone of the report was pushing it in another direction. Just to touch on the fact that patients don't really get a look in this report, I will give you some feedback in the words of a patient who was transferred to Brentwood from Basildon in June. There were no toilets, we had to use commodes and no washing facilities. Food left much to be desired. Sandwiches were always stale. We could only eat the fillings. Disgusting. So that is a patient's view of what it was like when Mayfield unit moved over. I mean, they were being housed, it wasn't fit for purpose. They were being housed in sort of MDF cupboards without really any space for there to be visitors. And obviously when it was a COVID end of life service and patients weren't, were fairly, were not awake and were not able to receive visitors, that wasn't such an issue. But obviously, as now there are no COVID patients being nursed on that ward, it really hasn't been fit for purpose since it's gone back to being a rehab ward. So I really, really do welcome this move to move Mayfield unit back. And I will protest and be vehemently against any move to move Thurrock services out of Thurrock. So I'll just plant my flag on that one. Thank you.
Thank you. And I'm sorry about that story, actually, Councillor. It's we don't want to hear that from anyone, and certainly that's somebody's loved one. So I don't think any of us can support that, and we really do want to get this right.
Thank you, Councillor. Yeah, my wind was sort of taken out my sails when we sort of changed direction at the beginning of that report. I really thought we was going to have to put up a fight to get the ward returned to Thurrock. So I am pleased that we've come to this again. I think we all agree that we are very keen to keep services in Thurrock. Councillor Vessel.
Thank you, Chair. Thank you, Stephanie, for that. As Thurrock Hospital I've known for many, many years, it's on the edge of my ward. I'd like to echo what everybody else has said. It's no good me saying it again. But can I just ask you about the change of use of the day room, which would accommodate another 5 beds? Is that to happen now, or is that just in the future in case of?
So that was previously. We had to use the day areas in order to accommodate those beds, but that's getting changed. So that was one of the criticisms that's been raised, is that people didn't have a space away from their bed, but that's being changed as we've had those health planners in, and we're about to invest in that environment.
So the day room will come back again,
yes.
Stephanie, yeah?
Yes, it's in the process.
Brilliant, lovely. Thank you.
Thank you, Councillor. Thank you, Stephanie. Mark Tebbs, would you like to come in?
Thank you. Yeah, I think this is a good decision. I think it's good that the beds are coming back to
to Thurrock during the kind of winter period. I think I'd also just to kind of reiterate, I think that the fact that 19 options were kind of considered as part of this kind of planning just does really reflect the complexity of issues that are trying to be balanced. So trying to balance the kind of throughput through the hospital, good clinical care for stroke patients, the community domiciliary care capacity, getting planned care kind of procedures back up and running. So just not to underestimate the kind of complexity of issues that are trying to be kind of to be balanced, one of which of course is location. So I think also the work to take a little bit of time to get some kind of independent clinical kind of views on what the best configuration is for Thurrock patients and how they get access to kind of very good quality kind of specialist care. I really welcome that too. So we can look at that in the round and can consider kind of it from all angles. And I think I would probably just try and reassure really a little bit that part of the kind of COVID reset work is also looking at how we move more services into the community, into primary care, what opportunities there are for outpatient services to be delivered in Thurrock. You know, you'll be all well cited on the IMC work, and that is very, very much at the heart of trying to do what we all aspire to, which is have kind of care delivered closer to home by kind of, you know, and provide good opportunities to for Thurrock to be the place where people want to work and live and deliver good outcomes to our patients. So just a kind of a bit of reassurance that is absolutely the aspirations in the system.
Thank you, Mark. Yeah, as I say, I do welcome the return of it. At the same time, you know, we keep our fingers crossed that we don't hit a high peak in the second wave. Anything can happen. We don't know. It's uncharted times. I think we've learned from this first part what does work, what doesn't work. And let's hope we don't have to try and rethink things again in the future. Just lastly, bringing in Anthony McKeever.
Thank you, Chair. Yes, I've left colleagues to make the case for restoring services at Mayfield, because you'll have gathered from what Stephanie said that this was about planning services clinically, the best things for patients. And that's why it's the right answer to bring services back to Mayfield. I've thanked the staff from Mayfield on the wards at Brentwood, where they've done a splendid job. This is just the flip side of that coin, getting them back to home base. Stephanie has done an enormous amount of work to plan these changes and go through all those horrible business cases and stuff. But I'm grateful also to the councillors and to the HOSC for its support when we had to make a difficult move in a crisis circumstance. As you rightly point out, Chair, we had to do something temporarily. I think it's been a while since I've had such difficulty to restore services, but Mark is absolutely right. In terms of the concerns about the future, Councillor Holden has hit the nail on the head. The MOU with the healthcare partnership should actually enable us to develop local services at place and to broaden the range of services with integrated medical centres, as Mark has outlined. You also have a vibrant set of primary care networks in Thurrock. I've met the chairs of that. They will augur well for the future. That is where the strength and the power of services in Thurrock comes from. It won't be happening up at the healthcare partnership, where I spend too much of my time. It will be happening on the ground with you. So I'm very pleased to offer the reassurance that people are looking for in terms of our commitment to building services locally. Thank you, Chair.
Thank you, Anthony. Councillor Holloway and Muldowney, can you keep your questions brief for me, please?
Yeah, thank you. I just wanted to say, following Mark's comment about the amount of work, I hope we do, as a committee, always recognise this hard work. But I think sometimes we do forget to just praise you enough, really, about, and we don't underestimate how much work you've been doing. It is an extraordinary piece, and as I said, I can completely understand. I can't understand what it must be like as clinicians to have to make these large-scale moves. I think what I just will reiterate is that sometimes we feel in Thurrock that when the decisions are made clinically, and we completely understand that, we feel that some of the services locally and some of maybe the buildings locally haven't always got the investment in the way other areas might have done, and we don't want Thurrock's areas and facilities to suffer and other areas clinically prioritised because we've had that underfunding in the past, and to think of us as a strong player in that way. And I also just wanted to thank Councillor Howden as well. I think what we demonstrate here is that we're every councillor, not just on this committee, but we are all in agreement about these services. So you're getting 49 councillors in a complete agreement here. So, if you do decide to kind of move these services, it's all of us on the same page. And I think just two very quick questions. Sorry, Chair. Just with regards to the Mayfield staff, I understand this might have been a decision that was made quite recently in the last day or two. When will staff be told? And is it Mayfield staff previously working on Mayfield, or the staff transferring over so they don't have to move around? So when are they going to be told? Thanks.
So a letter has gone to them all today. And specifically, you're right, it's been a kind of a late decision coming to this place. But I certainly, myself, Tanya and other colleagues wanted to make sure we knew this was live. We knew that staff would hear this, and we wanted to be the first to tell those staff. And so they have been informed today. Not everyone will have read their emails, but we will be paying a visit there as well to speak to staff.
Thank you. Again, I echo Councillor Holloway's comments regarding the hard work that everyone is doing, and we are all on the same page. Councillor Muldowney.
Thank you, Chair. I just wanted to cut back really about, again, the IMCs being offered as a solution to, in terms of what services can be offered. And, first of all, the IMCs are still a way off. They're not here yet. We're still waiting for updates about what exactly is going to be in them. But also the IMCs have been lauded as going to be replacing the need for our hospital, which is going. Now, maybe I've misinterpreted, but now I'm kind of hearing that maybe services offered there might be replacing a unit in a hospital, another hospital that we've got. And I think I'm getting a bit worried that IMCs are starting to be used as a universal panacea. I still feel like I need more reassurance about the long-term plan for the Mayfield unit. It was, not that recently refurbished as a unit. And there are always going to be patients that need bedded, that, where care in the community is not actually going to be the right clinical fit for them. I just don't want us to fall into this trap of thinking that the IMCs are going to be able to provide all and everything that we're losing. I mean, I think they're probably going to be pushed to replace really the services at Orsett Hospital. We shall have to wait and see about that. I certainly don't accept that they could necessarily be a replacement for the Mayfield unit. Certainly, I'd like to see a lot of evidence to persuade me of that fact. So let's not have too much talk about the IMCs being a universal panacea. Thank you.
Thank you, Councillor. Yeah, definitely opening up another can of something that needs to be brought to the attention, and for us to keep an eye on continuously what is going on with the IMCs and what services it is going to hold. I know they are due up in, I think it's November, that we're going to try and bring it back up in to find out what is going on now, or March. I may ask for an update on the next meeting of that, see if there's changes. I know some work has been made on that for contract to start on one of the IMCs. Did anyone want to come back on that from Stephanie?
No.
If I may, Chair, I'm relatively new and therefore may have misunderstood things, but since I've been here, it's been my impression that the integrated medical centres is some of the innovative and forward-looking things that have come out of Thurrock itself. Certainly when I've talked to the GPs and the primary care networks, I'm getting a lot of strong positives about how they will help develop a range of services locally. If there are misgivings within Thurrock itself around the the integrated medical centres, I haven't picked that up properly yet, and you'll need to help me reframe that, because I've been trying to get behind them and to support the direction of travel that I thought Thurrock had set for itself, which seems to me entirely positive. And just to pick up Councillor Holloway's point, it always takes a while to execute decisions and to get all the clinical and operational things right. But just to quote from a note that I sent out towards the back end of August, when I put the final proposals to our team, I said, quotes, and I think it's 26th of August, staff currently redeployed from Mayfield Ward, based at Thurrock Community Hospital, can return to home base to support services required there over the winter. So we've been trying to put all of these things in place for more than 10 days. It just takes us a while to get all the particulars there. And again, Stephanie's done a tremendous job. So thank you, Chair.
Thank you, Anthony. Yeah, obviously the hubs were met with some sort of discord because we was losing also hospital to replace them. So we were trying to safeguard our hospital. Unfortunately, it has closed. And some of us do see the hubs as a poor substitute, and they may not be fit for population growth for Thurrock. But that's a conversation that we will go over and have gone over many times before in these meetings and in other meetings as well. So we'll go back over the next time we get the update.
I'll be glad to review that aspect if you want me to, Chair. Thank you.
Thank you. Roger Harris.
Just to reassure Mac, there's definitely no misgivings about the IMCs. I think it's the pace and the speed that people are frustrated about. So, Chair, we're more than happy to bring an update report, because there is definitely significant progress being made. We now have, for 3 of the IMCs, detailed specifications. We now have a very clear time frame. Obviously, Grays will be slightly longer because of COVID, but more than happy to bring a very full and detailed report back to the next meeting.
Brilliant, thank you. We are going to have to move on to the next item, unless they're really desperate. Councillor Holloway?
Sorry, Chair, I just wanted to come in on the IMCs just for complete clarity. I don't think there was ever anybody that didn't want the integrated medical centres. There has always been 100% support for further investment in healthcare. All of those have been recommended. What was always the upset was the hospital closing and what services were going to go into those centres and where that might be, and ensuring that all of the resources were kept in Thurrock. So again, it's a similar message, but again, never any upset about having these resources. Actually, we want them and we want the hospital, ideally. That's what we were hoping for.
Thank you, Councillor. Yes, exactly. Councillor Vessel, quickly.
Thank you. Thanks. Just wanted to say, I've seen plans for Thurrock Hospital and the IMCs, just to pick up Mr McKeever's point, that there's a lot of, and Councillor Holloway, there's a lot of positive out there now. We keep saying a hospital, All City Hospital isn't a hospital anymore, and I remember it as a hospital. It's a small A&E, and I think if the IMCs will be much better, because also it isn't near for everybody, and once you get the 4 open, which will take a little while, it will be good for everybody. If someone has to come from towards it, it's a long way, you know. So I think the IMCs are a good thing. If we get, you know, when we get them up and running, it will be brilliant for fun. Just wanted to say that. Thank you.
Thank you, Councillor. Okay, so we were, that one was going to put out to consultation, but now it's all changed. So we're just noting that for now. Roger? Oh, you're on mute.
Basically, after that long discussion, we're noting the report, yes.
Right. Thank you, Roger. Okay, item 8, proposed consultation on the adult service residential fees changes and charges, sorry. The report can be found on pages 83 to 89 of the agenda. Can I ask Catherine Wilson to introduce this, please?
Thank you, Chair. Good evening, everyone. I'm Catherine Wilson. I'm the Strategic Lead for Commissioning and Procurement for Adult Social Care. I'll give an introduction to the report, but I'm sure Roger may want to come in and add to it. So this is our proposed consultation on adult social care fees and charges for non-residential services. So and it's for a specific service, which is domiciliary care. So I'm sure committee members will be aware, as we've discussed many a time before, the fragility of the domiciliary care market in Thurrock, and we've had a history of issues in having to bring services in-house. And the gap that we find ourselves in what we're able to charge as a kind of maximum rate of £13, and what the actual rate at the moment is that we pay providers of £17.06 has progressively got wider, as we haven't increased the charges and we haven't gone out to consultation. So we're coming today to ask for agreement from committee to go out to consultation around 3 particular options. So just briefly as background, each year, as you know, as part of the budget setting process, we do look at the levels of fees and charges that we have, and we want to now kind of move forward and look at the ability to full cost recover where we can within this area of domiciliary care. We do, however, have some very clear statutory duties placed upon us as a local authority around how we deliver services. And one of those is absolutely around ensuring that we assess an individual's ability to pay for the services they receive. So we're looking to 3 options around increasing for going out to consultation. Sorry, and I'm not quite sure what page it is because I haven't got the same as you. 83, 84. I think it's page 85. We're just showing you some comparisons around our charges and the fees that we pay to our agencies, rather, and what other local authorities pay, just to give you an idea that, you know, we're not too far off what other local authorities pay at the moment. And just to be clear, you know, that we're only considering domiciliary care at the moment, and we've got a list there of some of the other services that we're not considering, and the reasons why. And the important thing, just following on from what I said about the need to undertake a financial assessment, is that it's guided by a number of different things. So obviously the person's own individual financial situation, the benefit system as a whole and the benefits that people receive, and also the person's current living arrangements and their circles of support. As you can imagine, there is a great fluctuation in the number of people receiving services almost on a daily basis from adult social care. And also there's a fluctuation in the financial assessments and the numbers of people who contribute to their packages of care. So on the next page, we're looking at some of the bandings that we use when we assess people. So just give members an idea about how many people are not charged for their services. So people have a financial assessment and they don't have sufficient funds to make a contribution to their service. And when we actually analysed this in July, the number was 399, and that may be slightly more or slightly less today. We also we also have added here the number of people who do make a contribution to their service. And that's, when we did this analysis, it was 589 people, and that again may be slightly more or less as each week and month go on. That is, the variable charge means that some people will pay less than others, and again that's very dependent on their financial assessment. And we had 160 people at that date who paid in full for their care. So their care is provided to them either commissioned from a external provider or provided internally by social care, and they would pay the full cost of that care as they have sufficient funds to do so. In point 2.3, I've just detailed what a financial assessment entails so that members are able to see that that is, hopefully we'll see that that's a fair and equitable process. Everybody's financial situation is taken into account if they agree to have an assessment. And also people who have what's called disability related expenditure are able to have that taken into account as well. And so then once that's been done, our financial assessment officers will use a formula to ensure that the correct charges are put in place. And as I say, for a number of people, that is no charge at all. So we're now looking at the three options that we would like to go out and consult on. So the first is that the maximum charge remains at £13 an hour and we don't change that. That would be the least disruptive to the service and to service users, but it would mean that we would lose a potential income of just under £244,000 a year. The second option is to implement the maximum charge at £17.06 straight away, so from the beginning of the next financial year. That's quite a big leap for people, and sometimes when we look to increasing charges, people who receive services and perhaps are on the edge of being able to afford those services may be quite reluctant to come forward if they feel that they are going to be charged more money. So it can be quite disruptive for people. The third option is to undertake a phased implementation of increased charges over a 3-year period. So I've laid out some options there, £14.50 up to £14.50 in the first year, £16 in the second year, and in the third year, £17.06, or up to the maximum that we might pay to providers. Because running alongside this is that, providers have got considerable costs, and they are consistently requesting an increase in the fee that we pay them to provide the services. And so we want to kind of build into this consultation the ability to increase the charge should we need to, if we increase the fee that we pay to providers to provide services. And we would also like to, as soon as we can, start a consultation process that would be separate, but would be with providers themselves, to look at what a meaningful fee would be for them to cover the costs that they detail to us. We've recently asked our providers to give us some open book accounts to show us how they work with us and how they look to deliver services and what that costs. And so we want to have a meaningful conversation with our providers about what would be the right level of fee to ensure the stability of the market. So our proposal is to go out to formal consultation on those three options, and we will do that in a number of ways. We will do that on our consultation portal. We will obviously abiding by social distancing and considering COVID-19, try to have some meetings where we can meet with people and listen to what they're saying, and try to use technology as we're doing tonight, perhaps to be able to talk to people who use services in the wider community about their views with regarding those three options. Once we've been out to consultation, we will want to take options back. We want to bring options back here and also take them to Cabinet if committee are in agreement this evening. Roger, I don't know if there's anything you would like to add before we go to questions.
No, I'm anticipating there'll be a few questions, so I'll come back to respond to questions. Thank you, Catherine.
Thank you, Catherine. James Howden.
Thank you, Chair. I'm going to abstain myself from this meeting after I say a few words. I wanted to bring this to HOS tonight because I do fundamentally respect the committee. I was on it for about half a decade before joining the Cabinet. I did announce during my annual report at full council that my very firm view was that care fees would need to go up. So we've attempted to attack this from the most transparent way possible. I understand why all members of all parties for a number of years have either tried to freeze or tried to restrain increases in care fees. My clear view, taking this portfolio on in March, was that allowing a gap to grow between the cost of services and what's charged for services creates a great instability in the service. We've got to close that gap. It's not the type of funding structure that lends itself to long-term planning, and I want much better for our residents. This does a number of things. It's tapered in over. I'm quite clear of the option that I favour. I favour option 3, which is clearly something that is tapered in over a number of years. It is something that helps to close that gap, and as you will see on what I believe the third recommendation, it will allow us to program in a above inflation increase for the providers of domiciliary care. I want more money in the pockets of our domiciliary care providers, not to show them our commitment to their profession, but also recognising that they've increased financial pressures because of PPE and so on and so forth. And I think that's very, very important. There are obviously issues that we're not going to consult on. We're not going to consult on respite fees. I'm very clear that I think respite fees need to be protected as much as possible, protect formal carers and also informal carers, so family members who care. I don't want to see those fees going up. And finally, I would say that regardless of COVID and the very intense financial situation we find ourselves in, I would still be saying this is the right course of action. If we want to create a stable system that our residents can always rely upon, if we want to create a system that has got the flex in it to pay our workers more, we need to make sure the revenue is there. But fundamentally, 60% of our residents are still not going to either pay anything at all, or the increase that they see will only be a proportional increase. Only about 33%, only a third of the borough will have to actually see a full fare increase. So I think what is being suggested is proportional. I think it creates a stronger system, a system that has more money floating around our providers whilst protecting our residents, and also not altering the assessment criteria. So there was a great debate 7 or so years ago where everything was discussed. For example, if you're a blind person and you have a seeing eye dog, should the cost of that seeing eye dog count towards the cost of your disability? We're not going to revisit any of those eligibility criteria. Everything that is currently a criteria now that can be thrown into the means assessment will stay that way. That's not being reconsidered. So I think it's a reasonable approach. Is what I genuinely, honestly believe is the correct thing to do for the future of the system. But I wanted it to come here. I announced it in full council a number of months ago, and very careful to hear what OSC have to say, and obviously I will bear that in mind as the consultation formally comes to Cabinet later this month to be kicked off. And I thank you very much, Chairman, for the opportunity to talk to the committee.
Thank you, Councillor. Last year when we looked at this, I was very much pulling it apart and against rising any fees with the carers. I think looking on this with a new light, with the value that people need to be felt with our providers, I think going along in some way of increasing the fees is feasible. I always cringe when I look at means testing and financial viable and all that sort of stuff. I'm reassured that it's only with the top percent that we'll end up paying anything or an increase. But I'm going to bring in Councillor Holloway before her head explodes.
Meeting. Thank you, Chair. No, my head's not going to explode, but bearing in mind the opportunities that Councillor Haldon has to speak at full council and cabinet, I'm always surprised at the amount of time he takes up for HOSC when it's for members to be speaking, although I do appreciate how strongly he feels about the issue. I think it's very much for members to speak first, and then, if there's time, the cabinet member. On that note, I want to say, firstly, with regards to the figures, we get a figure for the first option about how much we wouldn't get. We get a figure for the second about how much we would get. And then for the third option, which is recommended, we don't get a breakdown of how much each year will bring in. So does someone have that to hand before I ask my follow-up question?
It's roughly about a third. Sorry, Chair. So it's roughly about a third increase. It's very difficult to give an exact figure because we have to do individual financial assessments on everyone, and it depends on their level of disability-related expenditure that will be ineligible. It depends on what income they're bringing in. Everyone's financial circumstances are quite different, so it'd be roughly a third each year.
Okay, I think for me, obviously, it will go without saying that I'm not happy about the increases. You know, as I was with the chair when he pulled it apart, although now obviously his allegiances have changed. I still think, even though it is the top, he says it's the top people that are getting, you know, charged the most, that's still an incredible increase, an amount. I think it's really, even spread over 3 years, you know, the amount of money people have got who are needing care is still very small, and this still takes money from vulnerable people. Now, this is obviously part of a wider budget, of a wider departmental budget. This is just one element of that. And whilst I'm, you know, welcome the fact that some services have been ruled out, I'm concerned that this rise isn't being considered as part of a range of proposals. And are there other options with regards to finances? We know that there is going to be a lot of financial difficulty. £15 million, I think, needs to be found, was what has been quoted at meetings. So I know this is one of many things within the department that's going to have to be looked at, and I don't feel comfortable piecemeal looking at a financial decision in this way, probably one of many to come. What I then ask, Chair, first is for, you know, my objections to be noted for the cabinet paper, and secondly, will you agree to put on the agenda for the work plan the detailed financial proposals that are proposed for the department with regards to fees and charges increase, but also all of the other cuts that might happen within the department for the committee to scrutinise, please?
Thank you, Councillor.
Can I come back on that, Chair, to answer some of those points?
Yes, quickly, Roger. Thank you.
So I just to reply to Councillor Holloway, all that we're actually asking at this stage is to go out to consultation. So we're not asking you to recommend or say yes or no. All we're asking at this stage is to go out to consultation. Well, that's what Cabinet will be asked to do. When the proposals come back, they will be seen in the context of other options, which may be a range of options. Yes, there is a difficult financial circumstances that we face now post-COVID, which every local authority is facing. So when this comes back for final decision, it will then be amongst a range of choices that members will have to make. So we're not asking you to say yes or no to that tonight. All we're giving you is the outline proposals. a change of this nature does require statutory consultation. So by the time we come to the decision-making process, which will be later in the year, we need to have completed that statutory consultation exercise. So that's what we're asking members to agree tonight.
I completely understand the point of the consultation. However, it's my experience in the time I've been a councillor, if you don't get the objections in early, consultation or not, it's minded and used as a passive agreement that it went forward. So in my experience, it's always best to note dissension. And yes, and Chair, on that point with regards to the work plan and seeing the detailed breakdown of finances, will you agree to put that on the agenda for us to scrutinise?
I will check back on that if that is possible. I see why not.
Thank you.
Councillor Rigby.
Thank you, Chair. Yes, I mean, given that costs are going to increase, be it national living wage, PPE costs and so forth, there isn't an option really but to increase the fees. I do think that such a sudden increase from 13 to 17 would be too steep. But I do think, plan number 3, where it's staged over 3 years, is sensible, and that people can prepare and plan for that. So really, I would, be supporting that option.
Thank you, Councillor. Councillor Muldowney.
Thank you, Chair. On the point of consultation, can I take it as read then that if this goes out for consultation and everybody replies to that consultation saying that they don't want any increases whatsoever, then there will be no increases?
I cannot give you that guarantee because it will have to be looked at in the round of all of the council's budget decisions. The purpose of the consultation is not only to get a straight yes or no, but also to look at, we would be doing an equality impact assessment. We'll be looking at, whether the fair charging policy is correct. So there'll be a range of parts of responsibilities. It isn't a straight referendum, I'm afraid. And when it comes back, members will then have the results of that consultation, and then they will have to make a decision on a range of budget decisions. So I'm afraid I can't give you that guarantee because members then will have a range of choices that they will have to look at.
Thank you, Roger, for your reply. Yeah, I mean, obviously you have to do consultation, which I presume is the main reason why we're having a consultation. I suppose I have to underline what Councillor Holloway has said, and I understand it's going out for consultation. That's all we're looking at here. But I do want to register my very strong objections. We've just been through this on Children's Services Committee about the transport for our SEND children, and again here we're seeing that cuts are being made for some of the borough's most vulnerable people. And I just think it's wrong. I just think it's wrong that these kind of charges are being put up for the most vulnerable. The most vulnerable in our area are being hit with increased charges. So I do object. Thank you.
Thank you, Councillor. Just to clarify that, the most vulnerable, we are looking at the people that can afford it the most, aren't we? That is the 60% wouldn't actually be charged? Is that correct, Roger?
Let me just get the table on page. Let me just get the table in front of me. Page 86. As Catherine said, that shows you I think it's around 1,200 service users. Yeah. When the report was written, as Catherine said, it does change fairly regularly. So there's a number that pay only 160 pay the full charge, but there's quite a significant number to pay the variable charge, which is a contribution, and 400 pay nothing whatsoever. So it's only 160 that actually pay the full charge. But that, again, it all depends on the individuals receiving care at the time and their individual financial circumstances. So this does change. But the point that the report was written, that was how the profile of payers worked out.
Thank you, Roger. And yeah, just to remind councillors, this is only for recommendation for the consultation to take place. I'm sure it will be coming back to us with a lot more details and options going forward. Councillor Massey.
Thank you, Chair. Also note, this will be going out to consultation. I echo Councillor Holloway's words of when the consultation comes, we can usually see roughly what's going to be coming back at the end of it. Nobody wants to pay more money, and I think with COVID, as well as public finance, personal finances are going to be pushed to an absolute limit as we're going to be facing an economic recession, for want of a better word. I think everyone knows it's around the corner. So yes, we're welcome to see what the consultation brings back. One question, when is it due to start and end? Because the devil's in the detail. I would like to see a lot more financial breakdown at the end of it. Thank you.
Roger, would you have that answer?
I think, Councillor, I only caught the end of it. It was about more financial breakdown when the final report comes down.
And when will it start and end?
Okay. Catherine, I think if you correct me if I'm wrong, but once this has been to Cabinet on the 16th of September, the plan is to start the consultation immediately after that.
Yes,
and Catherine, can you confirm how long it will last for?
It's a 30-day consultation, and yes, it will start as soon as agreement has been given by Cabinet.
Okay, thank you. And I do apologise. Councillor Vessel, you've been waiting. I have missed you. I do apologise.
Thank you, Chair. Yeah, I mean, as Roger said, we're only looking at the consultation. I'd probably be in favour of the third option, because I think the charging assessment is, I think, as Claire's laid this out, is really good. But as we're not there yet, I think my only worry is that, Claire, if in this COVID we're in at the moment, will it affect some of the stages where you might not reach, the people to get their consultation back?
Thank you. Catherine, could you come back on that? The problems of seeking to actually speak to people and get their views?
Yes, absolutely. We will send out questionnaires to everybody who receives services, and we will also put the questionnaire on the portal. We will also arrange that people can ring and speak to us if they need to, and we're going to also have face-to-face meetings, and that's kind of how we've done consultations previously, and that's been quite successful. So hopefully that will support us being able to reach as many people as possible. But we will endeavour to do that, absolutely.
Thank you, Claire. I just think it's sorry, Chair. I just think there's a lot of vulnerable people out there who don't emails, and they don't do things on the iPads and everything else. There's that vulnerable people we could miss. But as you said, if it's going out by letter as well, then it's a good thing, to get that back. So thank you for that,
yes.
Claire.
Thank you.
Thank you, Councillor. Kim James.
Thank you. I've come in at this point. I've been listening to it all, and obviously I was going to speak to Catherine about us being involved in that consultation to ensure that there's some independent views going out there. I'm a bit concerned about the 30 days for a consultation period. We've had many health services that have come before this committee, and we have challenged them on very short periods of consultation. It would be very unfair for me not to pick that up on this one. So we have a Thurrock compact, which is all signed up to, which is a minimum of 13-week consultation for anything that's going to affect a service. So I would like to raise my concerns around that part of it, and maybe look at that being a bit longer. 30 days is not long enough when you're going to people who are going to rely possibly on other people to read that letter to them, to explain it to them, and then to respond to it. I don't think 30 days is long enough.
Thank you, Kim. I think that's really helpful, and we'll review that in consultation with you, so that we get that period of time as long as we can. Absolutely.
Thank you.
Yeah, that's a very good point raised there. I know with some of the consultations I've been involved in, just even getting people waiting to read letters to them, it can take longer than that. Councillor Holloway, have you still got your hand up?
Mm-hmm. Yes, thank you, Chair. I was going to come in on about the length of the consultation, actually, because 30 days is just not long enough. I mean, Councillor Redstill herself said about people not, needing support to fill out it and need extra support, and that it's vulnerable people we're talking about. This is the vulnerable people. What I also just wanted to add, and I think people really forget actually, is that you might look at this and say, oh, it's just a few pounds, but when the council tax is increased by massive amounts of money, 4% plus the social care precept, when fees and charges, because some of these people will be living in council accommodation, when those go up, when the cost of bills and electricity and gas go up, when the cost of food goes up, you look at this in singularly and you say it's only a couple of pounds, but when every single thing in your life goes up but your income doesn't, how are they going to afford this? And actually, I think we should have a better understanding, not just of people who are on a variable charge or on a full charge. Where are they living? What's their income? What other, issues have they got with regards to, are they on benefits? Are they going to get benefit cuts? We don't have a good understanding of the people that we are charging all this money to. And I don't think it should be taken out of the context, which I think it currently is. And why is one of the reasons why I'm pushing for proper financial scrutiny on our work plan at the next meeting, Chair. Thank you.
Thank you, Councillor. Councillor Mardani.
Can I just answer some of those points, Chair? So, just to reassure Councillor Holloway that all of those things that she said are taken into account as part of the financial assessment. Are fair. I'm more than happy to circulate our fair charging policy. So there is a very detailed assessment of people's income, their outgoings, before any charge is imposed at all. So just to reassure you that is all taken into account.
Thank you. Can we see more of that detail in the reports that come back in that case, so we get a better understanding of the kinds of things that we're dealing with and the people as well?
More than happy to bring that back when this comes back to committee in a later in the year.
Thank you.
Yeah.
I think you're on mute, Chair.
I hope you haven't lost the chair. Oh, thank you, because there's no vice chair. Yes, I just wanted to come back on terms of, I think, yes, we are talking about vulnerable people who need some level of domiciliary care. It doesn't matter how rich or poor you are, the category is vulnerable. It's not to do with your level of income or whatever disposable income you've got. So just to clarify that, yes, these are some of the borough's most vulnerable residents, and to really support Councillor Holloway's ask that all the financial cuts that we're looking at, efficiency savings, whatever euphemism you want to make for them, we know that there's got to be 15 million savings made, and I would like to be scrutinising those on block. The ones that, because if they're brought back piecemeal, it's a very different conversation. I think we need to see them on block, and we need to scrutinise them as a substantial item on the agenda. Thank you.
Thank you, Councillor. Okay, so if we have just note in the minutes, obviously, Councillor Holloway and Councillor Maldoni's objection to that. As I say, this is just a recommendation of it going to out for consultation. And obviously, when he comes back, I'd hope to see a lot more financial data and the options that are going to be along with it. Would you be happy with that, Catherine?
Actually, can I just come back in? Sorry. Can I just come back in on that? And can we actually put in, add something to the recommendation about the length of the consultation?
Yeah.
And extending that to the 13 weeks and not the 30 days.
Very good point. Thank you for picking up on that. Yeah, Catherine, if we could actually, you said you were going to take on board and look at it anyway.
I will. Yeah, absolutely.
Brilliant. Thank you for your report. Thank you, Catherine and Roger. Okay. I'm aware of the time. It's coming up to the close of the meeting. We still have items on the agenda. Like last time, do we agree to carry forward with the meeting?
Yes. Agreed.
Agreed. Thank you. Okay, item 9. Procurement to provide autism specialist support services at Millennium Road. This can be found on pages 91 to 98 on the agenda. Can I ask Les Billingham and Catherine Wilson to introduce this, please?
So it's going to be me to kick it off, and then with Catherine as well. So unfortunately, Les can't be here tonight. So
right, thank you, Roger.
I don't think he is looking at the other. So I think this is a really positive report that will also be going to Cabinet in a couple of weeks' time about a new service development for young adults with autism and complex learning disability. Any director of social services across the country will say that this is most probably one of the most complex areas to find the appropriate service level, appropriate service provision, but is also potentially sometimes the most expensive areas of residential care. And it's a very specialised area. It is a growing area. And also because of some of the unique nature of Thurrock having two outstanding special schools locally, it's an area where there are higher numbers of young adults, young people with autism and complex learning disabilities than other areas. So we've been working with our preferred provider, Peabody, for some obviously previously Family Mosaic. The building is now nearly complete. We are proposing to go out to procurement for the service provider. This is a service that we know we're going to have to provide a service for. At the moment, we have to purchase extremely expensive, usually out-of-borough providers that are very often people having to live a long way outside of Thurrock. So there's been a commitment for some time as part of our autism strategy that we develop a local service. We know the numbers of young people coming through our special schools. We know sometimes that we are talking about extremely complex and expensive placements, sometimes £4,000, £5,000 a week. So this is very much not only an investor save project, it's allowing a local service to be developed. We also want to link them into local service provision. So we've got a very comprehensive offer through our skills and training provider in Inspire, and we want to link young people into the Adults Education College as well. So this, at the end of the day, this is a procurement report and is going to Cabinet to agree to go out to tender for the care provider. But as it was, I think, such an important new service for Thurrock, we thought it was useful for Scrutiny members to have sight of it as well, because we think it's a really exciting initiative for Thurrock. So, Catherine, I've mostly said everything in my context. I'm sorry.
Yeah, I think you have, Roger. Actually, I mean, I just want to echo what Roger's saying. You know, we work to support people who are on the autistic spectrum, and the drivers for us really are to try to support people to remain in their local communities close to their families. And that's often really, really difficult and heartbreaking at times, I have to say. And people who have autism find change very difficult in the main. And so moving away from a community that they're familiar with is actually very hard. So this has been a project that is very close to everyone's heart, really, to really ensure that young people can stay closer to home and that we can bring people back from residential support. And as Roger says, it's very much a good news story, and it's I think it's been hugely well received by families and people themselves with autism as a proposal, and having a specialist service will be invaluable in the borough, and hopefully maybe the first of many, who knows. Thank you.
Thank you, Roger. Thank you, Catherine. I'd like to add that this is such a positive report. This is sort of the completion of lifelong support within Thurrock. I know many cases where the families have to be separated when they get into their own living spaces and stuff like that. This offers a massive opportunity to keep them within Thurrock. Just opening up now to Councillor Redstall.
Thank you, Chair. No, it is a brilliant report. Having treetops in my ward, which is being extended sort of next, it's sort of a bit close to my heart too. So I think the only problem I've got, and it's a brilliant report, Roger, Claire, thank you on this. The only thing I have in page 92, 2.5, is that to have a diagnosis of autism and have a local connection or live within the borough. Just sort of make a bit more of that for me, because does it mean we are taking people out of the borough anyway, as long as they've got a local connection here? You just tell me a bit more about that. What I don't want is if we're just taking people from out of Thurrock and not the people that are already in the local connection.
Okay.
Was you able to hear all that?
I think so. It was about the local connection point. There may be people who have moved out of Thurrock into residential care, but previously, obviously, they were living in Thurrock, but they're not currently living in Thurrock, that we may wish to move back out of long-term residential care. So it may well be that it's people who obviously originated in Thurrock, but we've had to place them because of a lack of a local service, but they clearly do have their origins are in Thurrock, and we're still paying for their care, that we may wish to, if they're suitable, and obviously if it's appropriate for them and their family, move them back to Thurrock. So they're not technically living in Thurrock at the moment, but their local connection is clearly Thurrock.
That's right, thank you, Roger. Just wanted a bit of clarity on that, just to make, sure that we're not taking a lot of people who did live in Thurrock in the first. Thank you.
Thank you, Councillor. Councillor Massey.
Thank you, Chair. Thank you for the report. This looks really good. Looks forward-thinking. It's got lots of positives. I think it looks like a really genuine good news story, and it's really good to read it and see what work's being done. And I'm hoping we can even build on this and do more of it in Thurrock. I've got nothing else to say apart from thank you very much for the report. It looks fantastic. Thank you.
Thank you, Councillor. Councillor Muldowney.
Thank you, Chair. Actually, the point that I was going to raise has already been covered by Councillor Redstall. So just to say, yes, I really welcome this specialist development. Obviously, it's going to be cheaper than residential care, which I suppose is costs that we would be covering otherwise. So I think it's great that we're building on our provision for children that's attracting more autistic children and their families into the borough. And the provision of the support all seems very good. Thank you.
Okay, thank you.
Chair, could I just come back in?
Yes, of course you can.
Thank you. Roger, could you just, you can't answer at the moment, and do we know why there's an increase suddenly, or is it not suddenly? Is it Because we seem to be having young people with autism.
I think this is a maybe for a longer conversation earlier in the evening. I think there's no doubt that more people are being recognised as being on the autism spectrum. Now, whether that is just that we are better at identifying, and previously people might well have been identified as having significant mental health problems or personality disorder or learning disability, it may well be that they're previously not been recognised as such. So I think there's no doubt that there is a clearer recognition that more people on the autism spectrum. Now, whether that is a genuine increase in numbers or just, I think there's a little bit more complex. And I don't know if any of my health colleagues are in a better position to answer that, or Catherine, but I think that is less clear. There's certainly, the numbers are definitely growing. It's a particular issue for Thurrock because of the nature of less so Beacon Hill, but certainly more treetops in terms of the young people, young adults on the autism spectrum. Whether this is more around a better identification or more prevalence, I think is less easy to say.
Yeah. Okay. Thanks, Roger. Cheers.
Thank you, Councillor. Interesting question. I guess also being well known for a borough that has exceptional schools, it could be a target for people to move to with their children who have autism.
It is. Yeah.
Yeah, definitely. Okay, thank you for that, Roger. Catherine, that was brilliant. Such a positive news story. As I say, I do believe this sort of completes the lifetime support of people with autism within Thurrock, and it'll be recommended and supported to the Cabinet. Thank you. Minimum understanding of the across Mid and South Essex SCTP, an update of CCG merger and single accountable officer. Report found on page 99 to 142. Can I ask Roger, Harris and Mark Tebbs to introduce this, please?
Thank you, Chair. This is most probably not a report you want to do at 9:20 on a long evening. And I know this might seem, I mean, just reading the title out is most probably enough to send people to sleep, but this is a really, really important report because it's the product of a lot of work. And I know Ian Wake is on the call tonight, and he put a huge amount of work to get it to this stage. And I'd like to thank everyone that has been involved, both at the STP level and locally. We've had a long debate, as you know, about the footprint, the Mid and South Essex footprint, and how we get the right balance of relationships between what goes on at the place, under the Health and Wellbeing Board, under the individual local authorities, and what's best done at a system level. And I think to some extent it's been that debate will never go away, because I think there will always be that tension, but I think we've now got to what I keep calling this settled place, where we don't want to have any more, we don't want to have endless discussions and debates about governance. We want to actually get on to most stuff will happen at place. You know, the work with the primary care networks, we work with the local authority, work with the local providers. Most work will definitely have to come, because that's where the services are being delivered. But clearly we are part of a wider system. The NHS has decided that it wishes to move to establishing the integrated care systems across the country, and the footprint that we have locally is Mid and South Essex. So I think now this, marks an important milestone to actually put to bed once and for all the discussion around governance. I'm sure there will be issues and times when we can come back to it, but I think we've got a real strong recognition that the engine room change remains at place, but there are certain services and certain ways of working that we want to do consistently across the Mid and South Essex area. So it's consistency of outcomes and consistency of performance, not necessarily consistency of delivery that we're looking for. So I think this is a really important report, but it might be a little bit dry to take at 9:20 on a long evening. So I'm going to, that's my introduction. I don't know what Mark or Matt wish to add anything at all.
Yeah, I'll just echo that, Roger. It's a really important report. I think it lays the kind of foundations of the way forward and kind of settles that debate around system, place and neighbourhood. I guess it feels like it is very much based on the work that we kind of started in Thurrock. I think it reflects how we're developing our alliance working, how we're involving our kind of primary care networks in the kind of alliance infrastructure, and I think it's very welcomed. I think it's also kind of challenging around kind of some of the next steps that we need to take as we evolve our alliance. So kind of how we're going to kind of really build in kind of performance accountability, how we can evolve and develop some of the kind of contractual work. So I think not only does it kind of reflect and build on the work that we've done locally, but also kind of gives us some challenges around how we kind of evolve into the future. So the Thurrock CCG board kind of signed it off. I think it's an incredibly important and a document.
I think you're on mute, Chair. Is he frozen? I think your Councillor Ralph, I think your camera has frozen.
Oh dear. If only we had a vice chair to take over.
Looks as if you're frozen. Well, it's gone now. Maybe it's logging off and logging back on again. Jenny, do you want to sort of guide us through the next bit?
Sure. Ian Wake, did you want to pick up on points?
I just wanted to highlight, so I obviously welcome this, as Roger's alluded to. Quite a lot of it is work that I've produced, but it's actually based on the MOU that we'd signed off between all of the partners at Thurrock level last year. The important thing to me are the principles set out on pages 130 and 114. So subsidiarity principle 5 really does make the point that we should plan at the lowest footprint level possible unless there's a really good case to do something at a wider footprint level. And I think that's really important in terms of our work, in terms of empowering communities. But also the pragmatic pluralism principle 7, and it kind of plays into Roger's point that we need to aim for equality of outcome amongst our population, and there is huge inequality of outcome in health and care. We know that there is enormous health inequalities in Thurrock themselves, but that doesn't mean to say that we have an equality of input or one size fits all. And I think I really welcome this has been signed off and hopefully does put the governance debate to bed. But I think we need to continuously hold ourselves to account to what we have signed up to. There is always a temptation, I think, from the centre to allocate what they see as things in a fair way, but actually that means everyone gets the same. And when you've got huge diversity and heterogeneity of need between different populations, everyone getting the same actually counterintuitively perpetuates those inequalities. And the tough debate now is to actually challenge ourselves so that at times maybe everyone doesn't get the same, but we recognise that varying need between different populations and allocate resources in a way that addresses those needs.
Thank you, Ian. Hope you can all hear me now after the little technical problem I had? You okay? You can hear me?
Thank you, Councillor Ralph. We can hear you now.
Thank you. I do apologise for that. Is my new Microsoft Go decided to shut down on me. Okay, thank you. I haven't got the facility yet to see who's got their hands up at all.
Councillor Holloway and Councillor Muldowney have got their hands up.
Councillor Holloway.
Thank you, Chair. I agree with Roger that dealing with this at 9:30 at night is difficult. And I just want to give it, I guess, the just the welcome that it really deserves, because this has been spoken about for so long, and we know that, you know, everyone, and Mark and Ian and Roger have been, oh God, it feels like we all have for months, if not years, been talking about the importance of place and getting this in writing. So just really well done for kind of it being here, and I really, really welcome having this. I won't lie, it's a chunky memorandum, so it does cover everything. It's substantial. It wasn't easy to read. I don't work for the NHS, so it's very NHS speaky, but I'm guessing you guys all understand it, and that's the main thing. And what I would say is, what it really is really important is the place. As you hear every single meeting on nearly every single item, it is about Thurrock being at the core of our service delivery. We know we're part of Mid and South Essex, but for us, we want to make sure that we're thought of here first, even though some things will be able to be delivered wider. So yeah, just really, really welcome it. And I'm not going to go into the particular questions that I've got highlighted, but yeah, really just welcome it. Thanks all so much.
Thank you, Councillor. I will say, Councillor Holloway, I know that you had a level of input into this before, and all the questions that you asked and drove for within this situation on this merger. So totally, your work on this is totally notified on this. It's been brilliant. Thank you.
Thanks. Thanks, that's very kind. Thank you.
Councillor Muldowney.
Yes, I just wanted to say it is a very substantial document. I'm glad to see particular elements that there will be a focus on place, that we are looking at addressing inequalities in healthcare delivery and health across the area, and also that HOSC keeps its scrutiny role along with the other two scrutiny committees in Southend, and sorry, I can't remember what the other one is. Yes, that's all good news, and I can see that a massive amount of work has gone into it. I do reserve the right to be slightly sceptical about what will happen in practice, having lived through having our money taken from our budgets at very short notice, and still no details about how that's going to be paid back. Oh gosh, it must be at least a year later, and that information seemingly being very hard to come by, even when pursued by senior officers at the new trust. But having said that, in terms of the document itself, yes, it covers the bases that I wanted to see in there, and I do thank everybody for all their hard work putting it together. Thank you.
Councillor Ralph, you're on mute.
Thank you, Councillor. I guess it's our job now to make sure it's stuck to, and to keep going over it and make sure that it does what it says. Thank you for that. So we're recommending for that. It's noted and passed on. Brilliant. Thank you. Okay, so we're moving on to item 11, the work programme. So we've got the work programme for next month. One thing we will be adding to the work programme for next month is the CQC report on Basel Maternity Unit. We'll be bringing that in. If you could bring up the NHS for that. I say it's gained rather a lot of media attention, and it's quite a distressing report. And I've seen some of the emails that have gone out to us, inviting us for meetings and all that. So if we'd like to bring that in forward for the next meeting. Do we have any other items being added to the work programme. I know, Councillor Holloway, you said regarding the financial breakdown of the last one, if that's appropriate, we can bring that in.
Yeah, can I just come in there, Chair, just to say that I know in many years ago, the detailed line by line did come to scrutiny, and then it was decided that it would go, the detailed line by line would go to corporate. So it isn't the first time. I have asked previously for it to come to scrutiny, and it was decided that it would go to corporate. Why I think it's so important that it comes to scrutiny this year especially is that £15 million hole that we're going to be in. It might have been acceptable in previous years for it to go to corporate, but it's certainly not acceptable when you're looking at those kinds of cuts for it to go there this year. So I really do ask, Chair, that when they do say it goes to corporate, that you understand that it is an extraordinary year and that we need to see it for that reason. So that's why I really think we need it on, and especially for the November agenda, because if it gets pushed to January, we then can't feed back to Cabinet. And obviously, as you know, the budget meeting is in February. So if it doesn't come to next month, scrutiny will have had no say in very, very, very key financial decisions that will be going to full council in February. So that's what I would say on that. Thank you, Chair. And the other thing is just the COVID update as a standard. Thank you.
Thank you, Councillor. Yeah, we'll be adding a COVID update at the beginning of each work programme now to go through for the agenda. So we've got the Healthwatch update on all hospitals, the IMCs, verbal update, target lung health checks, mental health presentation providers. And so that will be also with the maternity report. Any other business? Councillor Muldowney, you had a question going back to the minutes right at the beginning. I didn't forget.
Councillor
Muldowney, you're on mute.
Yes, thank you for coming back to that, Chair. CERIC funding. We did, coming back to the minutes, so we were talking about, Mark actually said that there was a national bid was in process for domestic violence and sexual abuse, and CERIC had applied to get that bid. So I was wondering, is that funding now in place? Did they get that funding?
Yes, they were successful with that national bid.
That's great. That's great news. And the other item was Councillor Mays was talking about doing a deep dive, and I don't recall him saying it in the meeting, but in the minutes it said that a report was going to the mental health, the Health and Wellbeing Board in July 2020. I did have a look in the minutes to see that, but I couldn't see, because I think the question was about what specifically had been going on during COVID, had he been doing during COVID in order to make sure that services were there for people suffering from domestic violence, because he sort of sent out communications about, quite a few communications about that. When I had a look at that report, it seemed to be an update on an old report from 2018. So I was wondering, have I got mixed up, or I don't think he's here tonight, so maybe can anybody comment on that? What was the deep dive in mental health in terms of COVID? That's my question.
So there was a report to the July the 31st Health and Wellbeing Board that did cover an update on our mental health transformation plan. It did cover COVID and our response in terms of mental health to COVID. And it also did cover the future of our Section 75 agreement with EPUT. So that was all. It was quite a long report, but it was all covered within that report. Yes. And I think we've agreed for the November meeting of this committee to look a little bit further into some of our local providers. So we're going to be asking EPUT, we're going to be asking our IAP provider to come along and do a short presentation on their services. So we're picking that up at our November meeting in terms of local service providers doing short presentations.
And that's to the Health and Wellbeing Board.
No, that's coming to.
Oh, that's coming to HOS.
On the 5th of November here. It's on the work plan.
Great, thank you. That's great. Thanks.
Brilliant, thank you. Okay, any other business? Anything else at all? No? Brilliant. That concludes the business of the meeting this evening, and I can now declare the meeting closed at 9:38 p.m. Thank you all, and thank you for my first experience of being the chair of this group. Thank you, Victoria. Thank you all.
Thank you.
Thank you. Good
Bye.
night.
Thank you. Good night.
Good night.
Thank you for my first experience of being the chair of this group. Thank you, Victoria. Thank you all.
Thank you.
Thank you. Good
Bye.
night.
Thank you. Good night.
Good night.